Hi everybody, this is Iftikhar Pathan. I'm co-founder of Meraklis Technologies, who's doing this online impact summit. It is one of its kind and the first summit that we're doing for the NGO sector. I have a long list of exemplary speakers today, and I will start with introducing Nitish Agarwal, dear friend. So Nitish has had a background in healthcare. He's doing a lot of mergers and acquisitions. He's doing exemplary work as far as raising funds for large chains of hospitals and for individual diagnostics and so on and so forth. He's an alumnus of IIM Calcutta, and he's going to lead the session today. I would have loved to join the session, but unfortunately, I'm busy with another one. So, but I'm sure our audiences, all the NGOs, the social entrepreneurs, will have a lot of takeaway from what you guys discussed today. So, over to you, Nitish, and good luck. Have a fantastic session.
Thanks, Iftikhar. I must say that as Iftikhar said, we've done a lot of mergers, acquisitions, and investment transactions in healthcare. But thanks so much for inviting me here, where there's a lot of people who have looked at healthcare from an impact and a social perspective, not something that we have tried to do. So, really happy and privileged to be here with everybody, the audience. It's a commitment that I'm making upfront, and I was telling Iftikhar as well, even beyond this, whatever I and my firm can do to help people in any way that we can, I'd be more than happy to do it beyond this as well. So I'll just leave that there. But with that, thanks again to everybody, Iftikhar and your team. Let me quickly introduce the three co-panelists here. Very, very experienced group of people. First, of course, is Dr. Aloke Mullick. Dr. Mullick is an ex-military surgeon, but he has extensive leadership experience in the private healthcare space. He has been in senior leadership positions with Ruby Hall in Pune, Kim's Hospital in Hyderabad, and is currently the group CEO of Omni Hospitals in Hyderabad. Welcome, Dr. Mullick. Next, we have Dr. Parag Sancheti. Dr. Sancheti is the chairman of the Sancheti Group of Hospitals in Pune. For those of you in Pune, you know that Sancheti Hospitals is a final destination and a tertiary reference center for some of the most complicated cases in orthopedic care across the country. Dr. Sancheti, of course, himself is a specialist in arthroscopy and joint replacement and has done thousands of them across his career. Welcome, Dr. Sancheti. We also have Dr. Pinak Shrikhande. Pinak is a principal in Health Quad, which is a leading healthcare-focused VC fund in India. Pinak has, before getting into the investing world, Pinak has 20 years experience in critical care as well as healthcare operations, and is now within Health Quad, responsible for deal sourcing, evaluating those deals, making the investments, and obviously also working closely with the portfolio companies post that. So a big warm welcome to everybody. Thanks so much once again for joining, and to the Iftikhar and his team for having us here. Let me our topic for the discuss is opportunities for social enterprises in the health sector. I also am told that a lot of people in the audience are already doing that. Keeping that in mind, let me go across each of the panelists to ask a very basic question. Most healthcare is is impact by definition, isn't it? Whether we now run companies which are for profit or create impact, at the end of the day, it is direct impact, unlike a lot of other industries. What have been your personal experiences? What has been your journey like in terms of creating an enterprise that ultimately does impact people? How have you seen the soul and the heart part of healthcare, as much as you as entrepreneurs have to look at the numbers and the operating part of it? Maybe let me start with you, Dr. Sancheti. You've had Sancheti Hospital has a history, and your father started this hospital many years back. You've seen that over decades now. What's been your experience?
So what you want to know is how this pandemic has affected us, or what is the exact question? I didn't get it.
Before and after, Dr. Sancheti, what's been your experience in creating an enterprise in a hospital where you've seen impact of people of delivering that healthcare to a large number of people across the board? Well, COVID is a different ballgame altogether, but even before that, how have you?
Yeah, so running a single specialty orthopedic hospital has been a good experience. It's a niche market we cater to. There are very few single specialty hospitals of our ticket size in the country, and that puts us in a different market. And in orthopedics itself, we have seen that each subspecialty, like the spine, the joint replacement, arthroscopy, trauma, pediatric orthopedics, orthopedic oncology, shoulder, foot and ankle, all these things are growing simultaneously quite hugely. And people do understand that now there are expertise available, there are personnel, surgeons available to deal with these kind of problems exclusively. So that kind of approach has helped us to run this enterprise. My father started this nearly 55 years ago as a 10-bedded hospital, and we are now at 200 beds, creating our new hospital, which I don't know whether we started at the right time or wrong time, but we are making another 100-bed facility just next door, which will also cater to orthopedics as a subspecialty. So I see it's a good enterprise to be in. It's a good time, but this COVID has kind of put us off gear, and all our calculations and projections have gone haywire. So, but we have to deal with it. There's nothing we can complain about. We are handling the situation, and we'll see how things go.
Oh, fair enough. Thanks for that, Dr. Sancheti. Dr. Mullick, how's been your journey across the army earlier and across multiple institutions, building enterprises in the healthcare sector?
Yeah, it's been interesting. I'm an ex-army man, a surgeon. Started in Pune, director of medical operations in Lax. But after that, I realized that as director of medical operations, there's only this much you can do. You can just recommend things. If you want to make things happen, you need to head the enterprise. So I had to move out of Pune, of course, for that. I had to move out of the country for that. I led hospitals in the Middle East, in Europe, in Far East. And now back in India for the last nearly 10 years. I headed Ruby Hall, their beauty facility in Pune. After that, I was with KIMS. And now, for the first time, I'm doing a small hospital chain. I've mostly been associated with 7-star, 5-star hospitals, really big ones. Now, this was an interesting challenge. I took it as a challenge. Like, this was a hospital with a ticket size of 150 bed per unit, 6 units, and narrow EBITDA. And we did it's basically more like a consulting assignment rather than as a group CEO. We optimized revenue, we really benchmark costs, and we could create a big EBITDA jump in 1 year. And now we are ready for the next phase of growth. And I can very proudly say that we provide care which is equivalent to any corporate hospital at nursing home prices. That's a benchmark price. And still manage the same EBITDA. So I guess we are some kind of an industry leader in cost management, in revenue leakage avoidance. And we are soon going to add 4 more units in South India.
Good.
Yeah.
Sounds great. Thanks, Dr. Mullick. Pinak, you are in the investing world, but I'm sure you come across, because you're healthcare focused, you come across a lot of models coming your way. What's been your experience of, at the very highest level, healthcare for profit and healthcare for impact? Is there a gray line? Is there a black and white line? How have you as an investor looked at it?
So, HealthQuad is a healthcare investing firm in India, which we focus only on healthcare innovation and transformative healthcare. Basically, the whole idea is to invest in companies which will provide real impact on the ground, whether it's in terms of accessibility, in terms of affordability, quality of care, or bringing in efficiencies in the delivery model. So that's been our core focus. Of course, as you are well aware, healthcare impact, in anything that you do in healthcare tends to have an impact. but there are specific areas that we actually look at when we evaluate on an impact matrix what kind of impact the investment is doing. The more there, as you rightly mentioned, there is a very gray line between what is impact not for profit and actual impact which can generate a sustainable business. I think our focus has always been to look at businesses which are sustainable, which can run on their own steam without any kind of grant systems or any kind of backings. The whole idea is to use, or rather back those entrepreneurs who are able to create a story where it's a self-sustaining and self-growing business. So that's been the focus of HealthQuad's first fund. And now as we go into our second fund, which is a much larger fund, $100 million fund, we hope to do the same with early stage healthcare companies.
Sorry, I'm sure that's very useful for a lot of people here to hear. From an operating perspective, let me go back to you, Dr. Mullick. There is on one end, healthcare which needs to go up the value chain, obviously, because you can solve for more and more complex, issues and solve for things that could not be done yesterday or last year. On the other hand, India as a country, has basic issues. You don't even have access to a doctor some places. You don't have basic medical care. Primary medical care is not available. What are the challenges to delivering healthcare to the rural and the lower sections of economically lower sections of the society? What has been your experience, especially with the latest work that you're doing? As you said, this is very different from what you had done in the past.
Oh yes, I mean, so cost focus. Once you get a cost focus and you realize that lots of things that we do, actually, it may be good for business. It may be good for your top line, but is it really good for the patient? When you start getting that patient centricity, you realize that most of our corporate hospitals, and of course, Dr. Sancheti is in a niche place, so that rules him out. Most of the corporate hospitals are running for a patient model which is at the apex of the pyramid, tertiary quaternary care patients, and everybody is creating facilities, something like 1 crore per bed facility to cater to that, to small. You look at mother and child. Every investor wants to do mother and child. But every mother and child company is looking at the top end of the market. Okay. Whereas in India today, millions of deliveries happen at the lower mid and middle space. Even your society watchman will go for his wife's delivery. Where does it happen? In the unorganized sector? At 30,000 a delivery, 50,000 a cesarean. And
some of the trains in the last 2 months.
And if you can deliver it at this price point, we as a corporate hospital can every investor wants okay, there's a huge number of deliveries happening. Why isn't it happening in the organized sector? It's all happening in the unorganized sector. Yeah. It's still waiting for that first chain of say 100 units, which is doing 60 deliveries a month.
And that's a great point, Dr. Mullick. Let me follow it up with a question to you itself. You raised, for example, one of the most fundamental examples, right? I mean, children have been born since mankind started, right? As a species, maybe a million years. Yet today, in a city like Bangalore or Delhi or Mumbai, it costs $1 lakh to get of cost for a child's delivery. Why is that? Or rather, why is it that somebody wants to let's forget the part that somebody wants to pay for it. Why is it that there is cost which kind of justifies that kind of a pricing when on the other hand, like you said, it can be done at the unorganized level or at home or where it might be. Why does that paradox exist in the first place? I think we've lost Dr. Mullick.
No, I'm there.
Okay.
Yeah. So I thought that question went somebody else. Okay. Paradox exists because I don't know. There's a pressure to everybody. I know of chains. I won't name them. Once again, let's stay at mother and child, who wanted to enter the middle space, but they ultimately ended up chasing the upper space because there is a pressure to deliver immediately. There is this investor who is not willing to wait for 1 or 2 years. He's saying, okay, mother and child should break even within 6 months. You haven't broken even at 1.5 years. And then, of course, the operational team and the strategy team didn't think it through, didn't think their pricing through. If you have to compete with the nursing home, you have to compete with them at their prices. And then that cost metrics has to be the same. The operational effectiveness metrics has to be the same. So, so we can tell you, we are coming up with that ultimately. But this is a big space. The 10 chains can open in a mother and child space. The 20 chains can open up in the primary care space. This is where social entrepreneurs can come in. But when we started doing primary care, we started looking at primary care with an ultrasound machine, with once again, capex heavy. What does a neighborhood patient want? He wants a good doctor who can give him good clinical care, who can do basic lab, who can do probably basic x-ray, and that's it. And most of your cough and cold and this and that gets taken care of.
Yeah. And you hit the nail on the head. I think clearly what kills some of these discussions around not-for-profit and makes them become for-profit is the capex. I mean, at the end of the day, you need to provide somebody a return on the investment, and it's very difficult to find large donations for capex. Sometimes you can't find grants for OPEX. But let me take that to you, Dr. Sancheti. You are an ultra-specialized single specialty. You take care of patients. I mean, patients who come to you probably have been through a string of, initial care, diagnostics, etc., and then they come to you as a last resort for doing very high-end stuff. Do you see how do you see people who are economically weaker ever accessing that kind of healthcare? Is it going to have to be insurance based, or is there something else that you feel from your experience across so many years that can change, or what's the wish list if it could change to get there? I'm so sorry about that. Dr. Sancheti, hi. Did you get my question? I'll repeat it otherwise.
Who was the question?
So, Dr. Sancheti, I was saying, Dr. Mullick was discussing about, we used the example of mother and child, right, and why there is paradox in price. In your case, you are super specialized. How does somebody who's economically weaker ever access that kind of care? Does it have to be insurance based, or is there something else you've seen which could be on the wish list that if so and so happens by intervention of the government or somebody else, somebody who's economically weaker can access it, or a social entrepreneur can do something like what you're doing? Is it even possible?
No, it is possible, and we do cater to a lot of patients who are economically challenged. There are a couple of ways we do that. We have a trust hospital. We take patients through the CGHS, through the government quota, through charity commissioner, the IPF funds, the people who have the yellow ration card and are below the poverty line. So that's one group of patients. The second question which you asked was regarding the insurance, and the insurance, if you see, is definitely going up, and that is the way to go. Now, the third-party insurance through GIPSA is becoming very popular, and I see many patients who are insured through this, and though their rates are a little lower, but that's good in a way because that is affordable to the the middle class, the lower middle class, and that is increasing in a big way. And the future to healthcare is through insurance. That is for sure. Now, what kind of insurance is the big question. On one side, we have players like Bajaj, who have a different game altogether. We have the GIPSA, which have different, and there is another which has a high premium, but everything under the sun gets covered. So that is going to be the way forward. For our hospital, we have a special route for the economically challenged ones, and we very rarely would turn away a patient for the cost of low finance. And there are ways and mechanisms through which we do it. What I personally feel is that once this COVID pandemic is over, and hopefully soon, then there should be a very clear type of patient. One who was insured, one who was going to pay privately, and the third group of patients who have to be supported by NGOs, by the government, or by schemes, or by various kind of financial entrepreneurs, or through the CSR of some companies. CSR is a big thing, and we have tapped into some of the companies like the Bajaj, like the Force Motors, like the Kalyanis in Pune, who do help us on a time-to-time basis to deal with such patients. So I think that's another angle which we need to add. So no patient should be turned away, and whatever needs to be done should be done to ensure treatment to even the people who really cannot afford subspecialty treatment or specialized care. That's what I feel.
Oh, interesting, and that's very important because uh, you are right at the top of the pyramid, if you will, in terms of the level at which people come to you. So that's interesting to hear. Pinak, from an investor point of view, we were just discussing what are the models that you've seen work. I mean, we know that the line is gray between impact and for profit in healthcare. It's very difficult to figure out. Yet we know that a lot of social entrepreneurs in health who are healthcare focused and otherwise, they feel very frustrated sometimes when they go and speak to an investor and they're not able to make headway. What is it that works? What are the models that you think are more amenable to entrepreneurship with a little bit of a social angle? What are the things that make you as an investor stay away from something which has at the end of the day some good in it? What has been your experience?
See, when we look at models, whether it is, all of them need to have a social impact angle, of course, but they should make unit economic sense. And the customer acquisition cost for that economic maturity of that customer has to make sense. Unless and until those two get solved, we are basically trying to create models which will be burning money, and that is investor money, for a very, very long time. Now these are aspects which we take which we look at very closely, and help entrepreneurs think through these models very closely. We believe that primary care, of course, is one such thing where uh, you know there can be different models, and for that you will have to leverage technology, because it is not something which you can put with you put 100 doctors and trying to solve that issue, or you create capex heavy infrastructure to try and solve those issues. So technology will have to play a very, very important role in solving some of those very basic issues. And as Dr. Mullick rightly pointed out, it's not it's not the the most expensive equipment that you need to put there, or a very capex heavy equipment that you need to put there, but the model has to be thought through right, and execution on the ground has to be immaculate. I think those are the two critical things, especially in terms of primary care. But just let me give you an example which we tried. Uh, as in my previous life as a intensivist, I used to work at Fortis. I was director of critical care for 3 of the large Fortis hospitals in Delhi. We had at that time actually begun a program where we connected to tier 3 and tier 4 ICUs in remote areas in Uttar Pradesh, Rajasthan, Bangladesh, Nepal, to provide tele-ICU services. Now, I think we were ahead of our times at that point in time while we tried to do that. But today it's a classic case where tele-ICU services, especially in the COVID situation, could be the game changers. You can't. Everybody's talking about putting in ventilators, but unless and until you have the right manpower to run those ventilators, these machines don't treat patients. You will have to have the right set of doctors to treat patients, and that's where the marriage of technology and the right business model have to come in to kind of help solve some very fundamental healthcare issues.
Let me ask you something that we probably know the answer to, but just to kind of put it to rest, do you give any discount to entrepreneurs who have a social vision at the end of it, as entrepreneurs? Do you say I'll accept you as being less good at running a business just because you're going to create social impact, or accept making less money? I mean, we know the answer, but I just thought I'll get your take on it.
In real world, that does not happen. You have to be a good entrepreneur. It's the same situation while you're flying, the air hostess makes an announcement that in case of an emergency, please put on your mask first before you start helping others. unless until you make a good business sense, you can't be helping others.
And I think what Dr. Mullick mentioned earlier, Dr. Mullick, you mentioned, right, that, and Dr. Sancheti, in fact, was mentioning, unless you make money, you really cannot make it self-sustaining, then you are forever dependent on somebody else to support you, and those models just don't work. I've had the fortune of knowing a lot of folks in hospitals which are trust hospitals. Some of them work really well, some of them don't. The ones which work really well have one common characteristic. They typically have divided either physically or operationally their hospitals as for-profit and not for profit. The for profit part, and it might be just 2 floors or a few beds in a hospital, run like a for profit thing. They of course divert all the money out there to actually fund the non-profit, but they try and make the whole self-sufficient. And those are the models that work really well, because it's like capitalism versus communism. If you don't have capitalism somewhere within that model, the efficiencies start to die out. So grant-funded healthcare enterprises, and like we were discussing, healthcare being extremely capex heavy in some areas, just doesn't work out. That's been our experience as well. Dr. Mullick, what are in the current scenario with COVID as well as otherwise? What are some of the opportunities which social entrepreneurs would do really well at? I mean, we know that while Dr. Sancheti is being very generous in saying that high-end orthopedic, he does provide that to the economically less privileged people, but for an entrepreneur to come in and do that, it's going to take decades of experience and bits to do it, and you're a surgeon yourself. But what are if you wanted to make an impact in healthcare as an entrepreneur, what are the areas which would really create a lot of impact and probably are the lower hanging fruits?
COVID, what it has done is it has made hospitals realize that unless they start managing their costs, they'll go corporate very soon. Okay, so every hospital has started trying to learn managed costs, trying to understand. You'll be surprised that people pass out from premium institutes, I won't name them once again, and they don't even know the cost benchmarks of hospitals. I've interviewed people for head of unit positions. They don't even know the cost benchmarks of, so those numbers are not available. I mean, hospitals, they have their own personal numbers, and we who have been fortunate enough to work across many hospital chains in India and abroad, so we have a good number. So I said, okay, this is the benchmark that we need to, but this is not taught, right? Now, today in COVID, the biggest contribution that hospitals can do is to treat COVID patients at a reasonable rate. I know of hospitals right here in Pune who have 200 patients on bed, and before the government capped the prices, their ARPA was 10,000 per bed per day. Okay, which is very, very reasonable compared to what many other hospitals are charging. Post capping, their ARPA is 7,000. And they're treating them well, they're discharging them, and post-COVID, these patients are going to love these hospitals. In my time of need, these are the guys, and these are the hospitals where they're totally physician-driven. Many hospitals, they will charge you 40-50,000 per day. A physician will not even come, and he's too scared to come and see the patients. Here, the senior doctor, senior physician is himself donning the full suit and meeting every patient every day. He may be asymptomatic, but he'll go and meet them. So this is the first thing that you can do. Second thing is, we really need to figure out a cost and ultimately start working on high volume, low margins. Like Dr. Sancheti has very clearly said, and his rates are very, very reasonable compared to the space in which he operates. I know orthopedics, neurosurgery, you can charge any premium you want because the guy wants to get his bone fixed, guy wants to get his head fixed. But then if you control your costs and you're passing that benefit to the patient, that is what is going to happen. The third thing, which Pinak just now mentioned, is the use of technology. Anybody who has read the book, The Patient Will Now See You, will understand everything is gone on mobile. I buy my chappals on Amazon. Anything that you want today, whether a product or a service, you buy it on your mobile, right? Why can't you do the same thing on healthcare? The hospital, and I repeat this, I keep repeating this in any leadership forum, the hospital which leverages technology, moves to mobile, the first in India, will reap its benefit.
benefits.
Yeah.
What about technology for primary care, Dr. Mullick? Telemedicine is now doctors can issue prescriptions legally since March. That has led to a flood of consultation happening online. Do you think that it's still a citywide phenomenon though? Do you think it will actually impact?
It's a great thing which is it's a great thing which has happened. The biggest positive side effect of COVID is telemedicine. Earlier, it was very difficult to impress upon doctors. Guys, everything is available in India. Doctors are not unwilling to use it. Patients are unwilling to come on board. Now
Correct.
Both are forced to do it. And then post-COVID, they will realize, oh, this makes so much sense. So many studies internationally have shown that review sessions, repeat visits, 1/3 of them at least can be done on telemedicine safely. And all telemedicine consultations are prepaid anyway. And the doctor can always, midway through the session, tell the patient, look, guy, I need to see you. Okay. And that is like a lap surgery getting converted to open surgery. If a telemedicine session gets converted to a physical visit, you don't charge for it. That's all. Because the telemedicine sessions are always prepaid.
Prepaid, yeah. That makes sense. How about you, Dr. Sancheti? How's been your experience on the technology front in terms? Are you seeing a lot of your OPs going out? Is that an opportunity for social entrepreneurs to come in and help you, for example, in terms of the patients that you see? What would be some of those linkages from a higher medical care point of view?
So this is for whom?
Dr. Sancheti?
Yeah, so just a couple of quick remarks on what Dr. Aloke said. I entirely agree with him that we all have to treat COVID patients. And like when HIV came, we were all scared. But today we are operating on them very routinely. So we have to get used to the COVID era, and this is not going to go away. So today or tomorrow, if you already haven't operated on a patient, you will have to operate on a COVID patient, and then you have to, manage around it. Hopefully the vaccine would come, but I don't see it coming for the next 6 months at least for sure. I've been talking to Mr. Agarwal from Serum Institute, even though he's saying November, October, but I think it will be at least January. The problem is the strain is changing so fast, but we don't know whether it will be effective whenever it comes. But so till it comes, we have to get used to it. We have to operate on these patients, and the problem is we don't really know if we are dealing with asymptomatic patients. The question is whether we should be testing everybody routinely as a pre-op test or not. So currently, what we are following at Sancheti Hospital, we don't test all the patients unless they have some history of fever, they're coming from a containment zone, if they have any kind of signs and symptoms of COVID, then we will do it, otherwise not. The problem is again 30% of tests can be false negative and equally false positive. So we have to deal with that. So that is one aspect. What COVID has taught us is many things. One, as Dr. Mullick again said, the follow-up visits, the patients can easily be treated by teleconsultation. And when I start my routine practice, I usually have 3 rooms. So I will keep one room specially for teleconsultation. Patients are also happy with it. They are getting used to it, and they don't mind that seeing you on teleconsultation for a follow-up. The problem is the first time visit, I think, should be face-to-face, because that's when you have to touch the patient, feel the patient, examine the patient. The patient has to develop confidence in you, in your system, and for that a face-to-face first meeting is mandatory. But what I have seen, patients are getting confident with teleconsultation. They believe you, they rely on you, and that is going to be one thing which has opened up. For any person to inculcate any habit, they say that 30 days is what you require, but now we are more than 75 days into this kind of lockdown, if I may say so. And by now we have developed certain habits, which some of them which are good will continue in the long run. The question is, when are we really going to get out of this? I don't see that happening in the next 6 months. So this itself is our new normal. We've been working every day at Sancheti Hospital ever since the lockdown. Our staff is coming nearly 80%, and we have devised ways around it to deal with this issue. and so far so good. That's
No,
what I would say.
no, I
If you
also saw.
mind, after a few minutes, I'll need to just kind of log out. There's something happening.
I saw that, Dr. Sancheti. One final question, therefore, to you, and please do carry on after that. Any advice for healthcare entrepreneurs who are starting off in whatever form and manner in terms of trying to set up their own company, trying to make an impact? Any advice you have for them on do's and don'ts?
So when you say healthcare entrepreneurs, is hospital owners, organizations.
Or individuals who started doing something in the healthcare side, somebody
So
who's.
now I feel now the next 6 months it's not a good idea to start something new. What is going to happen is the smaller players in this sector, like the 15 bed, 20 bed, and 25, 40, 50 bed hospitals are going to be finished. They will have to join hands with 3 or 4 size of hospitals, and now is the era and time for partnership. So that is one thing which is going to clearly come out. Don't start anything new in healthcare at this point of time, because let things evolve. It's still evolving. Every day there are different guidelines. Every day there are different rules. Every day there are different kind of instructions coming for us how to operate. One day they say pottery is good. Second day they said AC should not be used. Third day they say that you should not use the space suit. So we really don't know which way are going. So once all that the dust settles down, then we should think. But now for the 6 months, any new project, healthcare project, should be stalled unless the bullet is shot and you don't have an option. Like for us, if I hadn't started the new hospital, I would have surely not opened it right now. But for me, the meter is down. The banks are already counting days and weeks, so we have to move on. But not a very good time to start new projects.
I appreciate the candor and the honesty there, Dr. Sancheti. I know you have to carry on, you mentioned, so thanks so much for having us. We'll continue, but really appreciate your time and
Thank you, Mr. Nitish. I look forward to seeing you in person. Thank you, Dr. Alok.
Bye, Dr. Sancheti. Bye. Hope to see you soon.
We must meet. Let's connect offline. And thanks to Iftikhar for inviting me.
Will do. Will do.
Thanks.
Thank you.
Now, new way now. No shaking hands.
Dr. Mullick, same question for you. I mean, we have about 10 minutes left. Any advice for budding healthcare entrepreneurs, do's and don'ts? I know Dr. Sancheti was very, very honest in saying don't do anything new, it's not the right time. But probably he was also looking at it from a hospital perspective.
This is the right time, I guess. This is obviously the wrong time to do something capex heavy. Obviously, this is the wrong time to start a hospital. Which brings me back to since Dr. Pinak is operating out of Pune, which brings me back to a typical Pune problem. We have been involved in so many, hospital repurchase deals in Pune which never went through. A model that is so successful in Hyderabad is that, of course, you got EBITDA valuation of the hospital. Then the newcomer, he doesn't take over the asset. He just says, okay, I take over your hospital, your operating hospital, the license and everything. I will pay you rent for the asset. The asset remains yours.
Great.
So for a small price, he takes over the hospital. He puts in operational excellence. He has 3-4 units. He can do whatever model he wants to do. And so many hospitals have got resuscitated like that. In Pune, everybody said, okay, this building is worth so much, this land is worth so much, give me 100 crores. Now 100 crores, that banda will make a new hospital, right? So with this asset light model, of course, Omni is totally asset light. We don't own any one of the facilities. Okay, so that model works if you are looking in terms of asset acquisition. Now, assets obviously are cheaper right now. The second thing is technology-driven companies. They are actually right now creating value for hospitals, and at the moment, like as I said, hospitals which go the mobile route earlier, which capture the patient's imagination on the mobile, will do much better in the future. And I always recommend people to read The Patient Will Now See You. It's a beautiful book. And so many such interventions are coming up from technology companies. We are participating in 3 such ventures. I recommend people to go through the Omni Hospital website, so omnihospitals.in. It is probably the most mobile optimized website in the country. You can probably see Max Healthcare website on your mobile and see the Omni Hospitals website on your mobile. See the difference. It's very, it's absolutely a different website created just for the mobile experience, right? And on the website you get a AI-driven chatbot which will tell you everything about COVID, which every question that you want to ask about COVID as per latest WHO standards, right? So those kind of things, and now we are rolling out across the enterprise video consultation and telemedicine. So all these things, these are basically tech entrepreneurs who are working with us. So, and the more you do such things, you can tech entrepreneurs working in the healthcare space, having focused products. This is the time for them to sell it to hospitals.
So thanks so much for that. Appreciate it, Dr. Mullick. Pinak, last question to you, and then we can open it up to the audience for any Q&A. What are the areas in healthcare which you feel are good, which are exciting to you, or which are things that entrepreneurs could take forward? How are you seeing the market right now?
So I think in terms of healthcare delivery, certainly telemedicine is something which is found its feet right now, especially after the government's intervention in changing the rules of the game. It has been around for the last 10, 12 years, but it really never got off the mark. But COVID has actually been the demonetization event for telemedicine, and we believe that that's how it will. That's how the way digital payment systems in India was catapulted by the demonetization event. Telemedicine would be the same would be happening with telemedicine with COVID. Second, of course, is I think there is this whole thing where people need to start thinking about healthcare financing. And, Ayushman Bharat has catered to the lowest sections of society in terms of providing some kind of insurance backup to that section. But there is a significant missing middle, as we call it, where the middle class, a large chunk of it is either underinsured or uninsured. And we need to find ways of actually getting them into the insurance bucket, or finding alternative ways of helping them, tide over their healthcare financing crises. Now, this could be through healthcare, soft loan program, through healthcare crowdfunding programs. There are multiple things that are happening. On the other hand, health insurance as a industry has always been strained by the losses that they have been making on the premium side of it, and they have to now evolve into something more intelligent, something more data driven, and that is the approach that they need to take on an individual level to create a customized package for the customer rather than a one size fits all kind of strategy. And those are the kind of things where tech driven models will help these companies make by themselves. Insurance companies may not have the bandwidth to actually put that model in place, but tech driven companies will be able to help the insurance companies actually evolve into much efficient systems and models. And last and not the least is the whole journey of chronic care, especially in a COVID scenario, where technology helping chronic patients manage their chronic diseases better, putting the onus of managing healthcare back into the patient's hand rather than a doctor guardian trying to take care of everything else.
Oh, that makes a lot of sense. I really appreciate that, Pinak, because you thought through the entire framework, if you will. Appreciate that. I'm conscious of the fact that we are running out of time. There are a couple of questions. One is on insurance, the other is on on collaboration. I'm going to skip the insurance one because Pinak kind of talked about that a bit. But I'm going to pose this other interesting question to Dr. Mullick, and I'm afraid we might have to stop after that. Dr. Mullick, there's a question from Mohammed Afroz. He says, what are the collaborative opportunities for hospitals and NGOs to reach out to people at the bottom of the pyramid? I mean, that's a great question, right? I mean, it doesn't have to be either or. How can some social entrepreneurs collaborate with larger facilities to actually deliver the care where it's needed most?
Yeah, why not? I mean, that's a great opportunity. I mean, say for example, in Inlax Budrani in Pune, they have a eye hospital, and they have a amazing program called Save Our Sight program, SOS, right? You pay $50, that pays for the surgery of one. It used to be $50. It may have changed now. It pays for the complete end-to-end care of one patient, for a blind patient, for his cataract surgery. Okay. So there are many hospitals would be willing. See, the hospital today, a big hospital, 700-bed hospital, it has, say, with its own cash-paying for-profit patients, it can probably fill up 350 beds. The other beds, it keeps on running after CGHS and this and that, and those payments. If a cash patient pays 100 rupees, the government pays only 50 rupees, and that too after 3 months, 6 months, 8 months, God only knows. Okay. Whereas if a NGO is willing to fund that surgery, they will definitely do it for 40 rupees if it comes up upfront, right? They will do it at cost. At least the hospital is benefited; it's recovering its fixed costs, right? The NGO is benefited; it is getting the surgery done at very cheap prices at a very big hospital, at a good hospital. These things will work. We are always ready to work with such NGOs who are willing to say, I sponsor 10 patients every month, right? But at this price.
That's a great point. I mean, I must add to this. I had the chance to work and contribute. I won't name the healthcare company, but they were into oncology, and they had a foundation, and I was part of the board of trustees of the foundation. And they did exactly that. The hospital said, "Look, my PET scan machines are idle in the night, right? But I have to keep them running, and I can't because of shifts. My people are there, but they're sitting idle. So at variable cost, I'll let you do a PET scan if your patients are happy to come at 10 in the night. Somebody who can't afford it was very happy to come at 10 in the night, and a PET scan, which otherwise the rack rate of which is 25,000 rupees, was being done for 5,000 or 7,000 rupees.
Absolutely. You said it.
I think that's exactly what you're saying. In other form and manner, it can be extended to even OTs and other radiology and admissions as well. Okay, interesting. I'm gonna just exactly 5:30. There is one question that has repeated itself on insurance. I'm just gonna probably just pose it again, and quickly we can add it, which is, why is insurance not really catching up? It's a very generic question, and all of us think about it every day. Why is it that insurance is not becoming broad-based? I suspect this question would have been harder to answer pre-Ayushman Bharat, but what's your take, Dr. Mullick, Pinak? I mean, feel free to jump in.
I guess we have been spoiled by LIC's endowment policies, where basically the whole idea was to kind of create a savings plan, not a cover.
Correct.
And the whole idea in a middle class person earning member's mind is that if I pay this premium, what is it that I get at the end of the year? And most people think that if I'm not getting, why I waste money on it? And it has started to change now, and I think it will continue to change after the COVID crisis. But the basic mentality has been that अगर मुझे कुछ मिल नहीं रहा है तो मैं पैसे क्यों डालूं इसमें, और मैं तो ठीक हूँ. Everybody is of this belief that I am okay today. Why do I have to waste money?
Waste money. Fair enough. Dr. Mullick, any quick words?
Besides, many insurance patients have had bad experiences. I mean, they're paying premium, but then there are lots of co-pays, or there are lots of denials. So health insurance needs to, Dr. Pinak will agree with me. I mean, even in smaller country like Jakarta, all the insurance payments were linked to their procedure codes. The insurance companies are totally driven by CPC. यहाँ पे भगवान मालिक है. There is a guy who is a veterinarian guy or who doesn't even understand allopathy, who is sitting and looking at the claims and denying things right, left, and center. So the ultimately the insured gets a bad experience. So that it's not a very good. It's not a very good kind of advertisement for your system, right? So.
And I think this is a discussion that can occupy an entire day. So
yeah, absolutely.
I'm going to stop it now. I'll just say this. Thanks so much, Pinak, Dr. Mullick, and of course Dr. Sancheti, who's moved on now, for joining in and your thoughts. And of course to Iftikhar and the entire team of Meraklis for getting us together. If anybody in the audience has any questions, feel free to shoot it across to us via the team here. But really enjoyed the discussion and really appreciate your time. Thank you, everybody.
Thanks, Nitish. This is very well done. Thank you so much.
Thanks,
Pinak. Hope to catch up later. Yeah.
Sure.
Okay.
Absolutely.
Bye-bye.